fourth plenary session of this meeting. And before we start, it is my honor and my pleasure as your president for one more day to hand out prizes to young talent. I think seeing so many young talents here tells me that we have a lot of potential. And I think we've seen that over the past days. I've attended several abstract sessions, which were really great. Young people presenting exciting research, all the way from things I don't know anything about, cells, etc., to outcomes research. Was really wonderful. Yesterday we had an event that was the moderated poster competition where we really challenge our young talent. I was there as well. I saw many young people very enthusiastic about their work, debating with the moderators, and it has been really difficult for them, for the moderators, to figure out who of those young people were the best. But we have identified 8. All the others, don't feel like you've lost. I think you've done a great job, all of you, but these people clearly stood out. So I'm going to call their names right now, and after I've called all their names, for those of you who are in here, I have a certificate. So come and pick it up if you're here, at least. And otherwise, you can come and pick it up at the registration area later. But that would be too bad, because you get to be in a picture, on a stage, etc. So that sounds like much more fun. So let me announce the first poster competition winner in the category of cardiac imaging, and that is Carlos M. Brandao. Cardiac magnetic resonance analysis of the coaptation length of the mitral valve after valve repair, and he comes all the way from Brazil. In the category epidemiology, Juan José Rodriguez Arias, with the abstract regression of preoperative pulmonary hypertension after mitral valve surgery. And he's from this beautiful area in Spain, Barcelona. The third winner in the category surgical valve, number 1, is Mostafa Abbasi from Seattle, Washington, USA. Title of his abstract was Detailed Stress Analysis of Edward Sapien and Medtronic Core Valve Devices. Is leaflet stress comparable to surgical Carpentier-Edwards Paramount Magna bioprosthesis? Congratulations. In the category surgical valve number 2, good, it's a woman, Mary Siki. The title of her presentation was Bicuspid Aortic Valve Repair for Aortic Insufficiency Without Aortic Root Aneurysm, Does Preoperative Annular Diameter Matter for Long-Term Durability? And she's from Philadelphia, USA. Congratulations. In the category Tissue Engineering, Pega Ebrahimi. Design of optimal right ventricle to pulmonary conduits for use in surgery for congenital heart disease. And Pega doesn't say where he's coming from, so, or she, maybe a she as well, I don't know. Okay, category transcatheter therapies, Laura Sanchez. Initial experience on patient selection for MitraClip XTR in a single center. Also from Barcelona, Spain. Yeah, come up here. So if you hear your name, you're welcome to come up. I'm going to finish yeah, there's 2 more. We have lots of prizes, huh? Yeah, come up here. In the category Valve Science 1 from Germany, Aachen, Matthias F. Menne. Influence of paravalvular leakage after TAVR on left ventricular work and coronary flow, an in vitro study. Congratulations. And finally, in Valve Science 2, Diana Fuller from the Medical University of South Carolina in Charleston, USA, and title is Desert Hedgehog Signaling Contributes to Mitral Valve Development and Disease. Another Warm congratulations to all of you. And please come up here if you heard your name called. So, let me see, who's up here? Yeah, you're Laura. I only have categories here. The transcriptor? Yeah. Congratulations. Tissue engineering. Let me see.
You need help?
Yeah, please. Congratulations.
Thank you.
And you should not stand behind the curtain. People cannot see you. Let's go up here, huh? Okay. Yeah, congratulations.
Thank you very much. Thank you. You guys should line up here so we can get a good picture. Line up here so we can get a good picture.
Yeah.
Get a picture. Okay, one more big round of applause for Emmanuel.
Yeah. Very good. Okay. Thank you so much and all the best. Yeah.
Well done.
Well done. Oh. Where are you? Which? So surgical. What was your?
Valve science 1.
Valve science. Okay. Valve science 1.
I just want to make sure you knew that she.
Yeah. Okay. Well. Thank you, and that was important to have a reward of new talents, because maybe Anneke, you can, I think, stay with us because you're going to be part of that session. So thank you for being there on this last plenary session that we're having, and that is really focused on network heart valve disease science today and tomorrow. And so a special thanks for all the speakers that will participate to that session, and particularly the two speakers that are not in the room. I'm looking on my notes here, and particularly Michael Vandenberg, who is from OECD, who will be live in direct via WebEx video conference in Paris, and Elizabeth McLean from ISHM. You will heard about that in WebEx conference from London with us. So we'll start straight away with Jane Grande-Allen, who you all know, famous scientist, and who will I have the pleasure to chair that session, and she will explain, because she's been involved into getting the research within the Heart Valve Society, and she will explain us the importance of valve research networks. Jane.
Thank you very much. Okay, so I'm excited to just tell you a little bit about the valve research networks for those of you who haven't been involved with them yet. And we want this to be a session that is very representative of what we have for, what we aspire to have for the spirit of the valve research network. So a little bit about that first. So Jose Pomar showed a picture of a rowing crew yesterday, and I loved that picture because I thought that it really captured all of the people who are involved in the heart team. So, and there's more than just basic scientists, surgeons, interventionalists, cardiologists. Also, we have mentors, we have trainees, there's industry, academia, nurses, engineers. So all of these people are working together as part of the heart team, and we think that being part of a valve research network can help you understand the scope of a particular research topic. So valve research networks were launched in 2016 at the HVS annual meeting in 2016. We originally, believe it or not, had 18 valve research networks. Now we have not 18. Some of them have not been sustained quite as much. Now we have this 7 or so. So there's aortic valve replacement, aortic valve repair. The aviator is run by Emmanuel. Mitral and tricuspid, VRN, basic science. There's 2 basic science VRNs, one for valve biology and tissue engineering, another one for more biomedical engineering and imaging, congenital and pediatric heart valve disease, and education is also an up-and-coming one, and it's about education of the patient. So, what is the purpose of the Valve Research Networks? Why should you go early in the morning to these meetings, or sometimes they're at lunch? So there's several different purposes. So all of them have a vision statement, and these are the things that they have in common. The plan is to really combine forces to advance our knowledge in a particular area, and hopefully this is going to be a multidisciplinary collaboration involving academics and medical professionals interfacing with engineers and in industry. And then perhaps you can propose new sessions for the next Heart Valve Society meeting, or plan for sustained engagement throughout the year, and that might be at smaller meetings. So for example, many of us in basic science attend the heart valve biology and tissue engineering meeting. There's also the development and sharing of research resources, and so there's a couple of the VRNs, at least a couple of the VRNs have registries that have been developed. And in doing so, really improve the treatment options for patients, understand how to educate patients, so through collecting of knowledge. Finally, we'd like to make sure that there's development of plans for your trainees as part of the VRN, identifying best practice, and really then growing your network and understanding that these problems are also worldwide. And so with that in mind, we think that these valve networks must be global. And so instead of just showing a regular rowing crew picture, I propose that maybe we should have a snake boat and a dragon boat as our valve network pictures. And as you can see, there's a lot of people on these boats. And I think that that's important and symbolic because in order to tackle valve disease, we're going to need a bigger boat. Thank you.
Thank you very much, Jane. I think indeed it's very important to be aware that those valve research networks are open to everyone, and that there will be a lot of people on the boat, and have also, maybe we should add also the politician, because we have OECD representative in that sense, and have the patient centered in the middle of the boat. But
about that.
But this is our goal in all of us. So we're going to start actually with the first approach by Dr. Padala, Mirali Padala, and who will present about the integrated approach for patient-specific modeling. And I think that's one of a nice example of taking the whole spectrum for the management. Thank you.
Thank you very much for the invitation to present here. I'm Murali Padala, and I'll be presenting alongside Wei Sun, and both of us are from Atlanta. To give a brief background of why I am here presenting, I started my career as a mechanical engineer working on hypersonic propulsion, and moved on to now being an assistant professor in cardiothoracic surgery, focused on trying to apply various different disciplines and tools from various different disciplines to studying mitral valve disease, and increasingly more now in heart failure. So at Emory University, the boat was a very nice analogy, because what I have been able to build there is a group of about 22 interdisciplinary people that includes surgeons, engineers, molecular biologists, and also now cardiologists, who are focused on a single problem. And this approach to building boats is probably something that I picked up from the different mentors that I have worked with, starting with Dr. Ajit Yoganathan at Georgia Tech, with whom I had done my PhD. And I had the opportunity to spend a year at Harefield, where all of you know how big and efficient that boat is, with Adrian Chester and Professor Yacoub. And not too long ago, I got recruited to Emory University by Dr. Robert Guyton and Vinod Thorani to build a program that would focus on mitral repair in these regards. These are my disclosures, and so are Wei's. So to just give a very brief introduction about the mitral valve, you all know that it is a very complicated structure, meaning that it not only works by itself, but also interacts with the left ventricle and the left atrium. And the dynamism between the two chambers and the mitral valve structures by itself lends itself a little bit of complexity, but also a lot of beauty in terms of its function and dysfunction as well. As you can see here, this is a CT reconstruction of a beating heart. What you see is that the heart is contracting, but along with it, the papillary muscles are moving in time and space. And you also do see the contraction of the mitral annulus and also the saddle shape formation of it. All of these different motions impose a variety of biomechanical forces and also optimized biomechanical function, where the different structures work in tandem with each other or required to work in tandem with each other to enable the most optimal function. If we forget a lot of things that we know about the mitral valve and get down to how the mitral valve truly functions, we need to go back and read the papers of Dr. Robert Frater, where in some of his most seminal papers, he talks about the anatomical principles. Not a surgeon-based principle, but an anatomical principle of how the mitral valve works. Until this date, I think a lot of confusion surrounding heart valves is because we don't go back to the anatomy. What he very simply demonstrated in mitral valve function is that the mitral valve has very simple control structures. You have a leaflet, anterior and posterior. You have multiple cords that emerge from both the papillary muscles and go across the valve to the other papillary muscle. And as the force balance changes across the mitral valve, these control mechanisms are creating a perpendicular shelf at the edge of the leaflet, of both the leaflets, so that they can come together into coaptation, as I show here. So what happens in functional MR? Something very simple happens, is that your annulus dilates, everything, the geometry surrounding it is perturbed. So this shelf that needs to form for coaptation from one commissure to the other never forms. So what you end up having is regurgitation. So our goal should not be to do anything else other than try to restore that shelf so that we have complete correction of regurgitation. As you can see here, this tethering of the valve leads to loss of that shelf and wide open MR. So my laboratory, and I'll be presenting that as case 1, have been focused on understanding what are the left ventricular predictors of functional mitral regurgitation in heart failure. And by understanding those, are we able to do something which is a lot more physiologically correct? And what are the different people and teams that we really need to get that done? So here I present a case. Firstly, if every single talk about functional MR goes to the fundamental mechanism on the first slide, saying that there is ischemia, there's remodeling of the ventricle, the heart dilates, that causes FMR. But if you actually see a lot of patients who are in end-stage heart failure and are coming for heart transplant, you actually don't see FMR in a lot of them, despite the fact that their ventricles are very enlarged. So the case I present here is 2 patients with heart failure of equivalent left ventricular volumes, one with severe mitral regurgitation and the other one with trivial mitral regurgitation. So what is it that is so different if it is not the left ventricle in these 2 cases? To answer that question, we went back to the basic anatomy that was taught almost 50 years ago. Is that for functional MR to occur, this edge of the leaflet needs to be tethered. And for the edge to be tethered, you need either one or both of the papillary muscles to be moving away from each other so that in the resting state, the edge of the leaflet is highly tethered and cannot deform anymore, as you can see in this en-face view. So building upon that, we tested the very simple hypothesis that if everything in the ventricles is the same, then does just the relationship between the 2 papillary muscles in time impact mitral valve geometry and lead to dysfunction? So what we had done at Emory, and this was my first foray into clinical research, being an engineer, is that I collected prospectively 64 patients who had MR versus did not have MR but were volume matched. And we performed cardiac MRI in all of these patients to understand what is different in patients who had MR versus did not have MR. We hypothesized that the basic difference is that there is shortening of this interpapillary muscle distance from diastole to systole that occurs in normal humans who do not have MR, or in heart failure humans. If it is preserved, they do not have MR, but the ones who do have MR are the ones where this interpapillary muscle separation is perturbed. So it's a busy slide, but the basic summary of this is that they were matched in every single regard. And after matching in every single regard, we measured this simple index and demonstrated that using cardiac MRI, and demonstrated that this simple index is actually a highly predictable variable that controls the amount of mitral regurgitation severity. So having done this, and we published this in JACC in 2014, and having done this, we wanted to next develop, building upon these anatomical principles, the ability to actually develop a surgical repair that can potentially correct functional mitral regurgitation in those who have it. So for that, we went to the animal laboratory and we developed a pig model in which we were able to either induce an infarction that included one of the papillary muscles, or an infarction of equivalent size that was remotely away from the papillary muscles. And what we saw was the former group, where there was perturbation of this interpapillary muscle separation, always developed functional mitral regurgitation over 8 weeks, whereas the other ones, despite having a large infarct and extent of left ventricular remodeling being equal, never developed functional mitral regurgitation. So this was another validation of a very simple concept from patient back in the animal laboratory. And in collaboration with Wei Sun's laboratory, we used the ultrasound data that we got from here to be able to confirm that the tethering of the edges of the leaflet that we had hypothesized initially is occurring because when this interpapillary muscle separation is perturbed, there is a high elevation of forces acting in the marginal chordae of both the leaflets. That is what restricts the shelf from forming. And we weren't able to directly measure those in these animals, so Wei was able to nicely demonstrate that using computational modeling. So that gave us enough confidence to take it to the next level, which is, can we do something very simple so that we can correct the functional MR in an effective way? So we are not the first ones to propose papillary muscle approximation, and there is enough data now out there that papillary muscle approximation done in the right hands and in the right manner with a focus on physiology and restoring geometry can very effectively correct functional mitral regurgitation. However, the challenge is that the few data that have emerged from Japan have shown that the extent of papillary muscle approximation has a direct impact on diastolic function of the left ventricle, and the extent to which survival is also seen after this procedure. So the pig model that we had developed provided us a very nice understanding, or provided a very nice vehicle to test these various different configurations of the papillary muscle approximation, and that is what we did. We created the disease in these animals and then performed different repairs. We had a group which did not get any repair, one group with just an undersizing annuloplasty, which is the standard of care today in repairs. And we combined both of them and then finally did papillary muscle approximation and survived these animals to 6 months and performed cardiac MRI on each and every one of them. The very simple observation, without going into too much depth, is that whenever you get the two papillary muscles together and approximate them permanently, you are able to mobilize the entire, both the anterior and posterior leaflets in systole quite a bit, because you are inducing a lot of slackness in the chordae tendineae of the mitral valve. And we measured that using cardiac MRI, and to summarize all of these results, what we have seen effectively is that the excursion angle, which is the extent to which the leaflets move from diastole to systole, is much improved with papillary muscle approximation, and the tenting area, which is the area between the mitral annulus and the leaflets, is significantly reduced. And that is the focus of every surgical repair anyway, so that you can have durable repair of the valve. And we see the same thing on the posterior leaflet as well. So having done this now, we obviously have to go the full circle, which is the purpose of a biomedical engineer or an engineer should be to take it back for application. So we started a NIH-funded clinical trial that I'm leading at Emory University, where all of the surgeons are actually working with me, an engineer, to perform papillary muscle approximation and compare it with annuloplasty and look at how the long-term outcomes are with very good imaging of these hearts and using that imaging to perform biomechanical modeling. And this is something that we are now extending to 3 more sites in the eastern United States. Moving on to Wei Sun's work. So Wei can answer questions, anything that you have regarding this. So I'll try to do justice to this. He's a computational biomechanics person who has worked in industry and then has come back to academia. So his approach to translational research is quite unique in the sense that he not only addresses questions that are of most interest engineering-wise, but something which is of most interest to industry as well. In this case that I'm presenting on his behalf, here is a 71-year-old male patient referred for TAVR who had classical low-flow, low-gradient severe aortic stenosis that was caused because of bicuspid aortic valve, where 2 of the left and the right leaflets were fused without any raphe, and there was moderate to severe mitral regurgitation. I suppose the question in this patient was that does implanting an Edwards sapien valve to correct the AS, can that completely eliminate the mitral regurgitation? Because some TAVR patients do get correction of MR, whereas others do not. So this is where predictive ability to predict things and probably plan helps, and this is where Wei comes in. So what he's showing on the left is the dynamic heart model, that the computational model that he has developed with both the aortic valve and the mitral valve on a patient-specific basis. And the left ventricle and rest of the structures are derived from the motion of the cardiac structures derived from these patients. And in this case, he applies fluid structure interaction on the valves, but imposes a motion boundary, I suppose, of the left ventricle to create these fluid dynamic structures. And what he finds here is that this fluid structure interaction model actually agrees quite well with the echocardiographic findings at baseline in these patients, and that the hemodynamics across the aortic valve and the mitral valve are quite equivalent between this fluid structure interaction model and the patient-specific echocardiographic measurements. So in this model, a transcatheter aortic valve, which is the Edwards sapien model, I suppose, is deployed. It is a balloon expandable valve that is deployed at various different heights, and using this model, he's able to test whether the different deployment heights affect mitral regurgitation, and whether that mitral regurgitation is dependent upon the height at which you implant this and the interaction of the frame with the surrounding mitral valve structure. So what you see here on the left is a post-TAVR 33% deployment height valve, and here is a post-TAVR 11% deployment height valve. And these are simulations where you can see that the interaction between the balloon, the stent, and the surrounding structures that include the myocardium and the mitral valve are quite evident. So following this deployment, the CFD model or the FSI is run again, where you can see the fluid dynamic motion of the blood through the mitral valve, left ventricle, and the aortic valve. And you get quantitative information of how the aortic valve hemodynamics and the mitral valve hemodynamics are. So what is shown here are the aortic valve hemodynamics, where you can clearly see that the height of this deployment has a direct impact on the post-TAVR hemodynamics of the aortic valve, and that specific height at which it was deployed correlates with what was actually done in this patient. And similarly, you can look at the hemodynamics in the mitral valve as well. And specifically in this patient, mitral regurgitation was not resolved, which was what the model had predicted, and which was what was done in this patient and observed after post-TAVR as well. So in essence, what I think and they can share more as he's on the stage, what we intend to communicate through this is that small valve networks that are focused at a given institution or in small areas or laboratories are growing, and it would be very, very beneficial, as Jane and Emmanuel have already indicated, is that these growing networks would really help us push forward some of the very clinically relevant work and potentially even help industry develop some of these devices in a manner where that is actually useful and not go in an iterative fashion back and forth. With that, I'd like to end my talk, and thank you for the opportunity.
Okay. Okay, so our next speaker, Caroline Boughton. We had actually, keep coming. Caroline is not able to join us. She had to return home. But the intention was to follow up on the mitral-specific integrated basic science clinical overview that we have for the VRN with an aortic side, and we will refer you to Caroline's work for that. So instead, we will skip ahead to Lee Silke talking about burning unsolved heart valve disease issues. Welcome.
Great, thanks very much, and thank you for having me. This was an interesting topic, and I had to give it quite some thought to decide which area to focus on. Quite a difficult assignment. So what we've done is I've just looked at some of the areas in which we focused during this Congress. So obviously congenital heart valve disease, rheumatic, the issues around degenerative disease, infective endocarditis, and then the whole group of other, which includes trauma and iatrogenic, functional, etc., that makes up all of the issues of heart valve disease. And so what I'm going to do in the first part is just flick through some of those and just think about some of the particular issues that we've been grappling with over the last little bit, some of which we've raised in this Congress, and then focus on a few other areas as well. So in terms of congenital heart disease and congenital heart valve disease, this is one of the most difficult areas, in fact, and relates to the fact that we probably don't know enough or sufficient about the development of the heart valve. So there's quite a lot of work in this area. We've heard some of it in this conference, but I think this is an area of growth and certainly an area of need in terms of research. The other big area is how to address heart valve disease from a point of view of surgery. We like to discuss the Ross operation in South Africa because Donald Ross was one of the came from the same university that we work from, and of course we're now looking also at the Ozaki repair. But both of those have got particular issues. They're quite challenging, and so there's a whole area of research around heart valve disease and surgery for children with heart valve disease. We look at the interventions as well as the surgery related to those. And the first panel is a very recently published paper. We're looking at using the melody valve in the native outflow tract rather than a stented outflow tract or a homograft. And then, of course, the issue with prosthetic heart valves in children is a very complex issue. And this is something that really needs a lot of work, is what are the right types of valves for children, especially young girls? How can we put valves in the various areas, and what is planned in the future? So here's a lot of issues just on this one slide, and I'm sure these will be featured in many of the society meetings going forward. So rheumatic heart valve disease, again, is an area where we can easily have a conference for 3 days just focusing on the burning issues in this particular area. One of the big questions is around predisposition of what makes a at-risk patient. And there have been several recent studies, these are the papers from Tom Parks, looking at the genomic analysis of rheumatic heart disease and what creates an at-risk patient. We are involved in a research network, the RHD Gen Research Network, also looking at that in the African context. This is, again, an application of genomics looking at group A strep. So the streptococcus, that actually is the start of the continuum towards rheumatic heart disease, and this is in pursuit of what is that holy grail, but the streptococcal vaccine. We know that secondary prophylaxis is the evidence-based intervention to try and reduce further episodes of acute rheumatic fever. However, penicillin generally in the world is at a low supply, and intramuscular applications on a regular basis is not the ideal. So there's a lot of work going on at the moment looking at different formulations of penicillin. Is it possible to do it via a subcut approach or a different antibiotic altogether? I, as an echocardiographer and a pediatric cardiologist, I've been involved in a lot of screening work, and this is detecting rheumatic heart disease at its absolute earliest. This has also changed over the last 10 years, where we've gone from using big echoes to miniature echoes and now even to handheld echoes, and also using task shifting and task sharing. This is a training program in Zambia teaching radiographers to detect rheumatic heart disease at its earliest. And again, talking about networks, the Invictus study is a study currently on the way, looking at novel using NOACs in patients without prosthetic heart valves in rheumatic heart disease, with only over 32 countries involved. And then I know Peter will allude to this later, but it's also looking at how do we develop the most appropriate interventions for patients living with rheumatic heart disease, and in this case, looking at valve replacements and possible valve repairs. So we heard a lot about degenerative heart valve disease in this conference, and it was a real pleasure for us to focus on that right in the very first plenary. We're now looking at transcatheter aortic valves in a new, different way, looking at novel indications, especially after Partner 3 and Notion 2, and trying to see whether these are appropriate for low-risk patients as well as other indications. And it was a real honor to meet Professor Cribier on the first day, but even more so to hear him say how it's interesting to watch his baby grow, and that maybe it's important to be part of that process that leads this on to new and different indications. This is looking at mitral annular calcification, a very challenging area, both in terms of how to deal with it interventionally as well as surgically. And the other issue around surgery is, again, looking at minimally invasive surgery, as well as surgery that's associated or connected with tissue engineering and all the biomechanics that we just heard about today. So again, degenerative heart disease, a whole range of issues that we need to look at. If we look at infective endocarditis, very interesting, looking at different ways of making that diagnosis. This is a paper about using PET scans in patients. This is the latest ESC guidelines, actually from last year, looking at an evidence-based approach. And then also the issue about infective endocarditis in a slightly different look. This is from Jack, and it looks at infective endocarditis after transcatheter aortic valve replacement and versus surgical aortic valve replacement. What was thought potentially to be an issue, you can see doesn't seem to be one when we've looked at it over a period of time. This is from the Euro scoring system, where we look again at different scores to be able to define whether the surgery for infective endocarditis is appropriately timed. So we've looked at all of those. And it's clear to me that when we look at some of these wonderful talks and the abstracts that we've seen, that we're dealing with these on a medical research and science basis. But what about some of the other issues? So the one thing is about real-world data and whether we are collecting real-world data when we do these science. And I'll tell you. Okay,
No, I just agree.
Oh, he's agreeing. I don't have a time in front of me, so I was worried.
You're fine.
Excellent. So whether we're collecting real-world data in the way we should. The other area is expanded use of the tools that we have created. Another important area is delivery, and it's not, I believe, appropriate to develop tools if we're not thinking about how we're going to deliver them to the appropriate people. And then, of course, the always issue of funding. And then all of this for improved patient-centered outcomes. So I'm just going to look at that very briefly, and I actually mentioned a lot of these in my first talk. So when we look at real-world data, and I ask you just to walk around this graph, is when we're talking about developing a new valve, developing a new intervention, these are what we're talking about when we talk about real-world data. So not only mortality data, but wearables, consumer data, disease registries, our electronic and medical records. And these are the kinds of data, cumulative amount of these data, that's going to go into programs, algorithms, artificial intelligence to try and develop the appropriate patient-centered outcomes. So when we think about a new burning issue and we're addressing it, let's us also think about how we're collecting these kinds of data around that particular issue. This is a very important one. So this is about underfunding for heart valve disease, and in particular rheumatic heart disease. And this was a very eloquent study from Colin and Tom looking at the objective evidence for underfunding. And what they looked at was the DALY, so this is from Global Burden of Disease. And again, you can see where the major disability-adjusted life years are related to rheumatic heart disease, over 10 million a year. And as I mentioned maybe earlier, more than, for example, breast cancer or leukemia. But when you look at that and you compare it to funding, it's quite dramatic to see how neglected the neglected actually are. So rheumatic heart disease is by far the lowest funded disease, a heart valve disease, when you compare it to the amount of DALYs that it's actually contributing to the world. Then we look at our global prosthetic heart valve market. You can see in blue the heart valves in North America, and in red that tiny little snippet that you can hardly count, that is Middle East and Africa, where most 80% of those with rheumatic heart disease actually live. The global TAVR market is thought to be worth an estimated $3 billion US, projected up to $5 billion US by 2020. And the blue are all the countries in the world that have a gross national product of less than $5 billion. And so if you put those two into perspective, you can see what it is that I'm talking about. This is about access to healthcare, and I showed this graph before because I found it very interesting that the European Patients Forum have dedicated themselves to Access 2030. And so what we're seeing over the next few years, and you're probably seeing it already, is a different type of patient. They're called e-patients. Mm-hmm. They are empowered, they understand their disease, they've gone to do their research, and they come to you with very specific questions in a very specific way. And what they need even more than a patient that we assume is not empowered is empathy, time, and attention. And that sentence actually comes from somebody who calls themselves a medical futurist. And so we talked about patients and how we can use patients to partner with patients, but also to be advocates. And I thought it important to mention two particular people here. Arnold Schwarzenegger, who said, "We've got this covered." I think you may or may not know he's got a bicuspid aortic valve. He had a Ross procedure, which lasted for about 20 years. He then developed homograph stenosis, needed a Melody replacement, which was not successful, and ended up having a surgical replacement. And then, of course, Mick Jagger, who told everybody that it was his heart valve surgery was just a walk in the park. It would be very nice to sit him down and explain what he had was not heart valve surgery, but also to use him to raise the awareness of heart valve disease around the world. The other thing that we always talk about when we think about delivery is that you cannot deliver high-level expertise and technology to Africa or to developing countries. And that's simply not true. So this is where we talk about blockchain and mobile apps and how we can actually bring that to developing countries and how useful that could be. And this is another paper that speaks about how new technologies can transform not only Africa's healthcare system, but those living in the countries with a heart disease. So we've got some unique opportunities, and I think this is one of my last slides, but this is a very important opportunity for integrated messaging. So in 2018, the World Health Assembly actually adopted a global resolution against rheumatic fever and rheumatic heart disease. And there's no other single disease that have had a resolution outside of HIV. So we should use that and make sure we use that in a way that fits with this priority pyramid so that we can advocate for heart valve disease. So there are multiple burning remaining issues across the spectrum, and it's clear that the science around those issues are being debated. I think it's also clear that we don't need to just do more. We need to do it better. We need to do it differently. We need to be disruptive. And as Prof. Cabrier said the day before yesterday, we need to be courageous. But we also need to consider the cost. We need to measure the cost effectiveness, measure some of the other data that I talked about. We have to see how we could adapt it to different contexts. We always have to talk about patient outcomes, not just in terms of mortality or morbidity, but how patients feel about what we do. And so patient interaction and quality, and use these combined messages. Two birds are always better than one stone to be able to do that. I'd like to end, simply because this is my last of my 3 talks, by thanking everybody for having me, but also to warmly invite you to Cape Town. This is the view from the plane, just as you're coming in to land, and hopefully one day the Heart Valve Society meeting will be in Cape Town. So thank you very much for your attention.
No, come here with us. Thank you very much. Again, there was a very enlightening talk, and that makes the direct link with Peter Ziller, who is going to talk about optimizing rheumatic heart valve disease patients' outcome through network science. So it's a direct application through the Cardiac Surgical Inter-Society Alliance, and we'll thank you very much for explaining what it is all about.
Thank you. Liesl has beautifully highlighted how the cardiologists were for years and years ahead of us surgeons. We had individually done a lot, and Magda Jakob's Chain of Hope is a very good example. But as a collective, it took us quite a while to finally wake up to the enormity of the challenge of rheumatic heart disease. And I want to report back to you that eventually we have woken up. What this slide shows you again is that the cardiologists were ahead of us. This fantastic study is also one where Liesl was involved, which shows you where the disease is. But what we never knew, and none of us really knew, was how many of those need surgery. Because anyone in the field will agree that we have a very high pickup rate, even particularly under children if you do a screening, but this is not the same number of patients who will eventually need surgery. This picture in black and white on the left is one of the last ones Liesl showed, because 2018 was really a very important year, not only with regards to the World Health Organization, but also, as I said, for us surgeons to get our act together to say when prevention fails, when all the measurements which our colleagues have been taken with secondary prophylaxis failed, what's the number of patients which should have an operation and doesn't get one? And I can just preempt my remaining slides with that one number to tune you. It's more than 500,000 patients which we estimate would need a life-saving operation at the end of rheumatic heart disease and don't get it. This is also from the Watkins paper, and it shows you that we were all a little bit mistaken by believing that rheumatic heart disease is getting sort of milder and milder by the decades. You see the top gray bar is the mortality per 100,000 patients, not just related to a growing population, in South Asia. And the bottom ones, the other gray one is Sub-Saharan Africa, and you can see even if there are trends, and only the brown curve is Eastern Europe, which went down. So mortality is still an issue, and mortality means that someone died who shouldn't have died if he had had an operation. So what we did was, at the occasion of the 50th anniversary of the first heart transplant, at the end of 2017, we were really privileged to have the whole world in cardiac surgery in Cape Town. And we organized for the day before the celebration a dialogue which we called the South-North dialogue, one which emphasized that it doesn't help a lot to send generous scholarships to Africa to allow young surgeons to participate in another coronary bypass surgery course in Boston, but it may be a good idea to educate all our colleagues in the North that the biggest problem for cardiac surgery is actually in the South. And the outcome was the Cape Town Declaration, signed by all the CEOs of all the big companies, by all the editors of the journals, hundreds of famous cardiac surgeons, but most importantly, by all the big cardiac surgical societies. And the outcome of that was, it was published in 9 journals simultaneously, and the outcome was that an umbrella organization was formed which contains representatives of all the big cardiac surgical societies. And the very first step in action was to determine the global needs in cardiac surgery. And we asked all the participants from those countries which are red on this map, representing 3.2 billion people, to really prepare themselves for the meeting thoroughly, and some of them for more over a year, to really get all the statistical results from their country. And you can see on the curve on the right side, the first thing was to determine the magnitude in cardiac surgery of the epidemiological transition. Do we have the same number of rheumatic patients in a developing country and just replace them by a number of degenerating patients? Well, on this curve in blue is degenerative disease and urbanization. And you see on the very right, countries like the US and Germany operating 1,300 per million a year, and the majority is blue. If you go to the left side, red is rheumatic heart disease. Developing countries, they need less. They need 350 operations per million, but it's still a lot, even particularly if you consider that they have practically no access. And as an example, India, for instance, you can see that still 43, almost half of the Indian population which needs heart valve surgery, needs it for rheumatics. Then we looked at the number of cardiac surgeons available per million population, and that was quite interesting because it says very little. You can see in India you have 1.1 surgeon per million. In Germany you have almost 12, and in Brazil you have the same number. And still you have a different delivery towards the poor in Brazil compared to Germany. What was interesting too was to split the difference between the private sector and the public sector in these countries and relate it to the Gini index. And if you look at, of course, looking at Germany, you have a very balanced delivery in the private and the public sector. But if you compare countries like South Africa with Iran, they have, on the one hand, a similar GDP. They deliver under the line almost the same amount of cardiac surgery. But in Iran, you have the same number, similar to Germany, going to private and public patients, whereas in South Africa, we give 800 per million to the private sector and 50 per million to the public sector. So therefore, Gini index 63 reflects that well. Just a quick glance at India, for instance. We know now that the overall need in India is about 630 operations, half of a fully industrialized country. The actual delivery is 123 per million, which means every year 130,000 patients are not getting a life-saving operation for rheumatic heart disease in India. China opens a new airport on a daily basis, but if you look at the delivery of cardiac surgery, again, about 630 needed, 123 per million are being delivered, and in China too, almost 80,000 rheumatic patients a year are not getting the operation they would need. And what is also interesting is the Chinese data are particularly detailed. And you can see that 56% of their hospitals operate less than 100 patients a year. So, and these are, of course, all in the rural areas, because in cities like Beijing, you have the biggest heart center in the world doing 15,000 cases a year. So one can see here already something needs to be introduced which goes beyond the standard approach. And this is the sad story of Africa, where we have for more than 1 billion people these few white dots, which add up probably to 2 American cities with regards to their private institutions alone. So the limited access to heart valve surgery for the majority is an issue. And if you look at what the access is, 80% of the population has therefore no access to cardiac surgery, even in countries like India and China. And if we translated it, it would mean that 4,000 and more additional cardiac centers would be needed. It's very unlikely that that can happen. So therefore, what is also important for our inter-society alliance is that one aspect is to tie in tertiary institutions with innovation, and this is just what we have done in the last 10 years in Cape Town, to develop simplified transcatheter, long-lasting transcatheter solutions, which general surgeons can use to replace heart valves. And to just round off the picture, this inter-society alliance, it represents the American Association of Thoracic Surgeons, European Association, Asian Association, and so on. And as a big partner, the World Heart Federation, which is the community of all cardiac societies worldwide. And they are an integral part of this inter-society alliance. So the very first step now at the upcoming ATS meeting in Toronto in 4 weeks' time is to introduce an action towards the low-hanging fruit, where we say all over Africa we have here and there centers which do cardiac surgery, but they can only do 50 or 100 cases, then they run out of money. And what we want to do is now, we will announce at the ATS the conditions for these centers to apply for support. A prerequisite will be that they will have to have a very strong local driver who is the champion. They will have to have government and their own institutions fully sign on. And then, if they get selected, and we will initially select just as a pilot case, one in West Africa, one in East Africa, and one in South Asia. And if they get selected, they will benefit from a transparent umbrella of international societies going fundraising for them. So they cannot expect that the societies pay for the programs, but the transparency and the weight will come in. And that brings me to my concluding slide. So the call for submissions for the pilot phase will happen now at the ATS meeting in Toronto, and the selection will happen in the subsequent 5 months. The winners will be announced at the European Society meeting in October, and at the same time, with the help of the World Heart Federation, we are also going to start a registry of what is available in cardiac surgery on the back of one which has been initiated by the cardiologists a little bit earlier. So in summary, I can share the good news that as surgeons we have woken up that we need to go beyond flying out missions for a week with 40 people, operating 8 children, returning, that we need to collectively recognize the need for creating local capacity. And we made a big leap last year. And hold thumbs, I think, if the pilot phase goes well in the next year, I think we will fly to new heights. Thank you for your attention.
Well, thank you, Peter, for that very. No, come with us on the panel, and it was very important to share, just to make sure that. So for the people who wants to submit. What is the deadline, and to whom should they send application?
It will all be announced after the ATS meeting. So what you saw on the one slide will be more or less the conditions that one needs to have. The institution have signed on, the government needs to pledge support, and then we will most likely use the Geneva-based address of the World Heart Federation for collecting the incoming applications.
Okay. Well, thank you very much, and that makes the direct link with the second part of our session, which is related to evaluation, because we have seen the unsolved heart valve disease issue and all the different topics, and that comes also to the question of evaluation. And I'm very thankful to have, maybe we can see Elizabeth McLean on with us, that is from London, and she's going to talk about the global standards to evaluate patients' outcome. Why do we need them? And I hope we can see. Can you? Yes, we see you. And hello, Elizabeth.
Hi.
Thank you very much for being with us. And so maybe you're from ISHRM organization, and we're very pleased to listen to you and have you on board. So thank you very much. And we're very interested to listen on the global standards to evaluate patients' outcome. Why do we need them? And thank you. Please go ahead.
Hi, thank you so much for the invitation to speak today. I know that some of you possibly have heard a bit about ICHOM already in the past, so I'll try not to repeat too much. But just to get started, I'm going to share my screen with you. Okay, I think you should be able to see that.
Yeah, we see very well.
Perfect. So I'm a program manager at ICHOM. I've mostly been working on helping hospitals to use the standard sets which ICHOM develop and to really integrate them into their routine practice so that we can have better evaluation and comparison between different hospital sites. So who is ICHOM? We were founded in 2012 by thought leaders at three leading organizations, the Harvard Business School, with Michael Porter, BCG, and the Karolinska Institute. We're an independent organization and not-for-profit. And we do have ambitious goals, I would say, primarily around Michael Porter's theory of value-based healthcare, and especially in using outcomes measurement to create this value, that being patient outcomes over the costs of delivering those outcomes. And so we're driving the adoption and reporting of these worldwide. We're collaborating with a lot of different national groups as well as international groups such as the OECD, who you're going to be hearing from a little bit later. Just to move on. Sorry, I think my slides have, there we go. So ICHOM has really identified the lack of standardized outcome measurement that really represents what's the most important to patients as one of the key global barriers to driving healthcare improvement. To date, we've really seen that most of health outcome measurements has been focused around clinical metrics and primarily mortality measures. And this really represents a lack of information about what the patients really want to see from their treatment. So what's really important to them in terms of their functional achievements following any treatments. For example, do they have chest pain when they're trying to pick up their grandchild, something like that. So these sort of more patient-reported measures, but which really represent what the patients want to achieve following their treatments. The second key problem really is that where hospitals are collecting outcomes measures, these aren't necessarily in a standardized form. So one hospital might be using one tool, another hospital will be using another, and then this really stifles the ability to compare between hospitals and then to really see where you can learn from best practices. And this has really slowed the pace of change within the healthcare systems. So moving on. Sorry, my slides are quite slow. Come on. So in terms of collecting outcomes measurements, what's the key final outcomes that we're wanting to be seeing? And this is that patients will be able to really choose their provider, but also the treatment that they receive based on the outcomes that they want to see, and also to be able to compare those outcomes and costs so that they can choose providers which are providing the best value of care. Clinicians will also be able to improve their quality of care by comparing with others. Hospitals will be able to differentiate into areas in which they're providing superior outcomes and really become a global leader in that area. Payers will be able to negotiate contracts based on the results and not volume. So we see this in concepts such as bundled payments and outcomes-based commissioning and outcomes-based payments. And that's something that's we feel will really begin to drive value in healthcare. And the life sciences will also be able to market their products based on value and to be able to show real-world evidence of how their treatments can improve patient-related outcomes relative to costs. And so how does ICHOM really work towards this value-based healthcare strategy? Primarily, and what I'm going to be focusing on today is on our definition of global standard sets. So this is around 10 to 15 outcomes which we've developed based on a consensus method and which we feel are really the most important to patients and which every healthcare provider should be trying to implement and measure. We then help different hospitals to use these sets and to really integrate outcomes measurement into their routine practice and care. And that's primarily what I've been working on at ICHOM. We're now at ICHOM also moving into more collaborative projects where we're able to then pool data and benchmark hospitals against each other, do some risk adjustment so that they're then able to compare their practices and also learn from each other by creating these communities of healthcare providers who really have a focus on value. To date, we've created 27 standard sets, including in heart failure and coronary artery disease. And for these sets, we have several framing principles, primarily that these are defined around a medical condition and not simply around one specific procedure. We're now also moving towards creating sets around population groups. So we are developing one on overall adult health, as well as one on pediatric health and older persons. So this will allow us to see more in terms of sort of multimorbidity and also health at a sort of broader broader scope and broader level. The standard sets that we create, they're designed to be a minimum set. So we have tried to be quite pragmatic in our approach and to say that although something might be of interest, is it practical and feasible to implement in the majority of healthcare settings? We do try and make sure that we are creating something that is usable at the end and that's not simply going to be an academic exercise. And with that in mind, we do try to make sure that the tools that we choose in that are free to use and have a broad range of translations as well. Our standard sets, as I mentioned, we really want to be looking at what is the most important to the patients. And with that in mind, we always have patients directly involved in the development of all of our standard sets through patient advisory groups who help us to decide on which tools and outcomes we want to be measuring. And in terms of these tools, we use the patient-reported outcomes measures, the PROMs, and these help us to really capture items such as symptom burden, functional status, and health-related quality of life, and often disease-specific healthcare quality of life. We also always include a minimum set of what we'd call case mix or risk factors. This allows us to then do some risk adjustment if we're pooling data and to allow for meaningful comparisons. One thing that we often see in the hospitals that we work with is that they'll say, okay, my outcomes are not quite as good as this other group, but our patients have 7 multimorbidities and they're all 100 years old. So that having this form of risk adjustment does allow us to at least begin to have some form of meaningful comparisons between different hospital groups. We also always include quite clearly laid out time points and sources of data collection so that it is clear for anybody using the standard sets on their own, like how they can go about implementing these, and also having very clearly defined definitions for each metric that we are measuring to try and make sure that everybody has the same understanding and is using the same techniques to measure each item. And this form of standardization will really, we believe, drive healthcare improvement, best practice sharing, and really help clinicians to understand what their patients are going through and how they can improve their healthcare. I'd like to just take you through a little bit about how we actually design our standard sets. We work with a very broad range of key experts and clinical leaders throughout the globe. We've got working group members from over 44 countries working with ICHOM. Although there's some areas of the map that we would like to work more with, especially in low and middle income countries, to make sure that we are creating something that can be used throughout the globe and is not just focused on high income countries and in Europe and the US. So when we create a standard set, we bring together a group of experts, including registry leaders, clinical experts, patients, patient associations, and also experts in patient PROMS measurement tools. The standard set development process is quite involved. It's quite methodical. It usually takes up to 9 months to 1 year to create the standard set. And this is really because this is a consensus-driven process. With the working group, we have multiple different teleconference calls, each with a round of Delphi process at which 80% is the cutoff for inclusion in the standard set. We also back up this process with 2 systematic literature reviews, one of outcomes domains, PROMS tools, and one of the risk factors and case mix variables that we'd want to include. We also have patient advisory consultations and groups and sort of focus group discussions, where we really do try to validate what we're proposing with the patients. And finally, we have quite a long open review period where we open the standard set up to the wider community and allow them to give their perspectives on what we're measuring, as well as if there's any definitions that are not quite clear, they're able to then give their opinions at that point. So it is quite an involved process. Organising consensus can be a challenge, and certainly we found that all of the people that we're working with are very engaged and that they do want to try and measure as much as possible. So it's really a balance between getting an essential set and something that is possible to implement in a variety of different hospital settings. When we're looking at the PROMS tools that we use, ITRUM doesn't design its own questionnaires. We use validated PROMS measures, which are being used broadly in different healthcare settings. We do try to make sure that where possible, there's limited financial contributions that are required for the use of those tools, and also that there are translations available so they can be used in multiple different countries quite easily. With that in mind, we always try and make sure that we're using something that is quite well established in the healthcare settings. We don't want to be going into a hospital and saying, okay, we know you're using this tool a lot, but we are suggesting this one. And also that the psychometric quality, we use the ISOQOL standards to make sure that those are of a high enough quality to be included in our set. So the final outcome of this process is a set of flyers, which just outlines the broad domains of the outcomes that we're measuring. Also our reference guides that have a very full and detailed set of instructions for using the standard sets in clinical practice. So this includes coding instructions and also sample questionnaires and any definitions of each measure. And we also do create academic publications for each of the standard sets that we're trying to develop. So they are interesting. It does document the standardization process. So that then when we're using them in the hospital setting, we do have that background as well. So just to give you an example of a set which we've created, we have one for coronary artery disease. So when we're talking about what really matters most to the patients, although we do have a lot of clinical metrics in here, including survival, and, for example, need for revascularization, reinfarction. We do also use several PROMS tools, the Seattle Angina Questionnaire, the Rose Dyspnea Scale, and the PHQ-2 for anxiety. And so looking at some of the questions that are involved in these tools, for example, in the Seattle Angina Questionnaire, we'd have a question such as, how much limitation have you had due to chest pain, tightness, or angina when, for example, lifting or moving a heavy object, such as a child or furniture? So then you can see, using these sort of questionnaires, we're really starting to look into the patient's quality of life and how their condition is really affecting their day-to-day function. So I think this is an important area which has been fairly neglected, I think it's fair to say, in a lot of healthcare settings to date. There is always a temptation to look really at just the clinical metrics, and often at the short-term clinical metrics. With these standard sets, we do want to try and create a longevity into what we're looking at, and looking at the long-term consequences of care. For the coronary artery disease set, we're suggesting measuring these PROMS tools on an annual or biannual basis. So we are really looking at the long-term consequences of care. And so within each reference guide, we also have our data dictionary, which really documents in quite a clear fashion how to measure each variable, and giving very clear definitions to what is actually involved in that variable, and also having response options so that if and when we pool data together with other hospitals, they're all submitting this in the same format, so that then we can quite easily extract that information and start to do some analysis. And I think the most important part of these sets is that they are usable, and that ITRAM itself is now starting to create communities of healthcare providers who are using these standard sets.
Elizabeth?
Yeah.
If this is a very interesting, but if we can allow a little bit of time for, we have another talk and a little bit of roundtable discussion, so...
Oh, no, sorry. That was my last slide.
Oh, I'm
so
sorry. I'm sorry.
Sorry. So yeah, just to say that we're creating communities who are now using these standard sets. So for example, we have one for coronary artery disease with 12 providers measuring outcomes, but also costs and value improvement strategies in their healthcare systems. So that was it. Sorry
no.
to go over
was
my time.
Thank you very much. That was very interesting, interesting talk, and good to understand what is all about regarding ISHAM standards, because this is familiar to you, but we're not all familiar with those standards, and maybe needs to be more familiar with them. And before we go on the, because I'm sure there will be some questions, but it will be important to have the last talk and then go for the roundtable. I'm very pleased to welcome Michael Vandenberg from OECD organization, who will explain us about the vision of OECD Minister of Health and what is the Paris program and how is it financed. So thank you very much, Michael. You hear us?
Yes, I can hear you loud and clear. Hello, everyone.
Yes, we hear you very well. Thank you very much for being with us.
Yes, thanks. Thanks for inviting me and for giving me the opportunity to talk about our patient-reported indicators survey. Fortunately, I could not be with you today in Barcelona, but I know it's a wonderful place, so I guess I'm missing all the fun, unfortunately. But anyway, we have technology these days, so yes. I will tell you a bit more what we're working on. So for those who don't know the OECD, we are an intergovernmental organization with 36 member states, which is the main part of the European Union, but also, for instance, the US, Australia, Canada, Japan, Korea, and so on. And we're doing a lot of policy work. We're collecting a lot of data. We're doing economic analysis and modeling. And we've also been active for instance, a very long time in the area of healthcare. So Emmanuel asked me to follow all the talks in this session, and this has been incredibly interesting for me. I don't have any medical background, so I'm a policy analyst. So I learned a lot today, I must say. But I want to start with a very fundamental question, which is, what really matters to patients? And if we think about this a little bit longer, we can think about, you can have very technical and clinical discussions about that. But in general, if you think about what patients want, the only thing you need to notice patients are just people. So what they want in their lives is usually the things that most people want. So what are their goals and things that they want? And that does not look like a hospital. That does not look like medical care, because most people don't want to spend their time in the hospital. It looks more like this. These are the things that people want in their life. They want to live a normal life with their beloved. They want to walk their dog. They want to work and have fun. And this is a normal functioning life. And this all seems maybe quite obvious, but it's quite amazing that we don't know so well to what extent our health systems really help to reach this goal, really deliver what people need. So, like Elizabeth pointed this out quite clearly, I think it is also one of the reasons why we have ICHOM, that healthcare systems seek to improve people's life and their ability to realize goals, but we don't know so much we don't have much structured information about whether systems are successful in doing that. We do have a lot of measures, inputs and outputs, but it's usually not so much about outcomes. So in the patient reported indicator survey, our objective is to produce information on what health systems deliver to patients. And as you probably know, the OECD has loads of data. So we have the biggest database with healthcare related data in the world about life expectancy, mortality, prevalence, incidence, and referral rates and admission rates. And obviously this is all very important. But what we want to add here is, how does healthcare impact outcomes? How do people function physically, mentally, and socially when they receive care? And also how integrated is care? And how do people experience the healthcare that they receive? Now, and this is even getting more urgent, because if we look across the OECD and across the world, I would say we can see that health systems are facing similar challenges. There are persisting inequalities. We have aging populations, which is basically good news because we live longer, but we also have an aging population, which gives us new challenges, and it also means that people live for a longer time with chronic diseases, and in many cases with multiple chronic diseases. And then, of course, we have the expenditures, because it's in most healthcare systems, it's a challenge to get a grip on the costs, to bend the cost curve. And we want to know that this massive amount of money that is invested in healthcare, that it really pays off. What do we actually get back for that? So if we look at health systems across the OECD, we think systems need to become more people-centered. And this is not just an OECD idea. The OECD is working for the member states. So once every 5 years, all the health ministers are coming together in Paris, and they talk about what is on the top of our policy agendas. What do we need to do to improve our health systems? And this is what came out in the latest ministerial meeting that we had in 2017. And all ministers agreed that we need to improve people-centeredness. So what does that mean? First, it means a shift from volume-based payments towards rewarding value-based healthcare, like what Elizabeth just mentioned. So we need smarter ways to pay for healthcare, and this needs to be explored. And across the OECD, there are many promising examples going on, such as shared savings models, population management systems, accountable care, bundled payment constructions. So there's a lot of experiments going on, and to what extent does it lead to better results or to more efficient results? And then care is often so fragmented and siloed. So we need to integrate this. And this is not just integrating healthcare starts with also integrating information, integrating data, the ability to exchange information across providers. And we need to move away from the more old-fashioned model from doctors knows best to more health literate people and systems. What was previously mentioned by one of the speakers, people who are, are kind of managing their own condition. And we need to move from process-based metrics, because we already have so many of that, towards measuring outcomes that really matter to people. Which is not to say that we don't need these metrics. Of course, I'm not saying that we don't need mortality statistics and these kind of things, but we need to also focus a bit more on what really matters to people. So to make this a little bit more concrete, what you see here, this is a graph from OECD data, and this shows knee replacements in a number of OECD countries. And as you can see, there is a nearly fourfold variation across countries. So then the question comes up, is this large variation in volumes? How do we explain that? And are there countries that are delivering too little care, or some are delivering too much? We don't actually know. We don't know much about the differences in results and outcomes between these countries. The only thing that we know is that in some countries it's a fourfold volume, so it's 4 times as high. And also thinking of efficiency and spending, it's like a question to ask whether these high volumes really pay off and really contribute to people's life. So to achieve better value, these are just a few examples of information that we would need and we hope to generate with a study like Paris. So for instance, to what extent are people in pain after hip surgery? And why do you get hip surgery or knee surgery? And because you're in pain, you have troubles walking. So are people actually better able to do that after the procedure? And can people live independently after a stroke? Or and also, you can read this on the slide, but also how do people experience the care that they receive? How care is coordinated? How doctors communicate with them? So, and unfortunately, I don't have any example here about heart valve surgery, but this really goes for all areas in healthcare, I would say. So talking about Paris, what will Paris do? The proms and prems are really key elements, and previous speakers talked about that. I don't think I would spend many words in explaining what is patient-reported outcome measures, measuring outcomes of patients like pain and fatigue and so on, and prems is about the experience of healthcare. So these are the key elements in all work that's been done in Paris. But we basically have 2 main streams of work. The first one is about specific conditions, and that has been started with 3 working groups: mental health, breast cancer, and hip and knee surgery. And a second work stream is a new surgery of patients with chronic conditions. Now, you might think, okay, what's the point of now starting working groups, because we just saw that ICHOM is already doing so much work on this, and they have created standard sets. The objective of these working groups is different. So what we're trying to do, we don't have an intention at OECD to reinvent the wheel. We actually really happy with what ICHOM is doing, and we are working closely together. They're also participating in this working group. What we're trying to do here is accelerating the uptake of prompts in healthcare. So what we're doing is bring together people from national registries and academics, people who are working with these data, and try to come to an internationally comparable set. So if everyone would comply with the standard set of ICHOM, that would also make our lives much easier. And I think for many people, because then it's fairly easy to come with an international set. But the OECD also provides a place for them to publish those data and to enable countries to compare each other. So we have been started with 3 working groups: hip and knee replacement, breast cancer, and mental health. I won't dive into that very deeply, but we had to start somewhere, and we chose to start with conditions that are high volume, high burden conditions, and that goes for hip and knee replacement and breast cancer. It's relatively easy to start with because there's already a lot of activity going on in the country. So we really try to work bottom up. We start with what's already being done and try to bring that together. Obviously, I cannot promise anything, but in the longer term, there will be more conditions that we will work on. And I can imagine that heart conditions would be one of the candidates because there's obviously also a high burden of disease in that area. Then, very brief, something about the new international survey of chronic conditions. So this is a survey focused on people with 1 or more chronic conditions. And these people are being treated in primary care settings. They get routine care. And this is actually the most rapidly growing group of patients across the world. If you look at a population in many European countries, for instance, you can see that almost half of this population has at least 1 chronic condition, and 25% has even more than 1 chronic conditions. As soon as you above the age of 65, it's almost 2/3 that have at least 1 chronic condition. And these people live with it sometimes, for 20 years or longer, and all the time they are being managed in primary care settings. At the moment that you have more than 1, and it's not an exception if people have 3, 4, 5 conditions, it's going to be complicated because you're receiving care from a range of care providers that are not necessarily working together. So we are focusing here on people age 45 and older. We're measuring outcomes and experiences, and we try to also align this with ongoing national strategies because, like I said in the beginning, there are many countries in the OECD who have this high on their policy agenda and already have a national strategy. So we try to align this. What we also try to do is link this data with higher levels. So it's not a population-based survey. We will be sampling providers and then patients within these providers. So we would also be able to look at variation in the country or in the region. So that brings me to my concluding slides. If you take home messages, we think the health systems need to become more people-centered. Again, this is not an OECD idea. This really seems to be a sort of paradigm shift. And to be honest, I've been working for more than 15 years in healthcare research, and I hear this rhetoric since more than a decade. But now it's time to move from rhetoric to action. And I think we saw an excellent example of ICHOM, because ICHOM is one of the international big players who have been, really moved this to a higher level. And we also, try to take that step from rhetoric to action. And this starts, before you can change the world, it really starts with systematic measurements. It's very difficult to change what you not measure. So systematic measurements of what really matters, international standards for outcomes and experiences. And of course, also not unimportant for the audience here, the engagement of patients, professionals, and policymakers is essential. It's critical for success, because no one would be successful in just imposing something to countries or healthcare providers. We need to do this together. Thank you very much.
Well, thank you very much, Michael and Elizabeth. That was very interesting talks, because we're not familiar with all that, and so that opened, I think, directly to maybe if we can go for just the introduction of the debate, and because that goes straight to our roundtable debate, which actually goes around we've heard a lot about integrated care valve research network, the missing things, and I think to launch the debate, I think it's important to be aware, as we have listened, that natural history of heart valve disease in the guideline era is mostly unknown. That market of heart valve therapy is exploding with multiple conflict of interest, and that there are undertreated disease like rheumatic heart valve disease, as we've nicely seen. And AV repair is, for example, also another topic that is not pushing compared to aortic valve replacement. The other things that is clear is that long-term patient outcome after surgical or interventional procedure are missing. We're missing those data on a large scale. There are multiple studies, small studies. The randomized controlled trial, the big ones are essentially controlled by industry. Doesn't mean that they don't have any value, but they are driven by some interest as well. And they are high quality, but we have to be aware of that. And there are also registries with heterogeneous way to report. And there is also, we have to be aware of that and starting cleaning on our side, that there are competitions among scientific society, cardiology and surgery, US, Europe, for data. And these are deleterious for, at the end of the day, the patient's outcome and the quality of care. So I think no one, after having seen all those talks, can disagree with the fact that there is a need for heart valve disease global standards to evaluate in a uniform way long-term patients' outcome. And there are basically 4 valves, so we have to evaluate the 4 ones and see before surgical or intervention on the valve, what is going on in the medical side. How do we do? Are we doing good with our guidelines? How do we evaluate the guidelines? And what could be the future criteria on a global evaluation? And when we treat the patients, how do we make sure that all patients are evaluated on a global way so that we can have a proper, on the same data set, evaluations of the surgical and interventional therapeutic that we're using to evaluate the results and the long-term patient's outcome. So if one mission of the Heart Valve Society needs to be defined, I think maybe it could be to coordinate a multi-society heart valve disease task force with all the different representatives of the societies, from cardiology, from surgery, Europe, US, the rest of the world, Asia, and so on, and to integrate the patients' associations, as we have seen, because what is important is what matters for the patients, and also integrate industry, because without their help, we don't have any tool to treat the patients as well. So I think there is a need to create heart valve disease global standard for long-term patients' outcome. But then comes the question, which global standards? Is ISHOM the only solution? And that's open to question to the panel and to the audience. And the second question is, how is evaluations financed long-term? Because so far, it's either financed by industry or by charity money on our free time during weekends and evenings without much help. And so how do we finance that? So those 2 questions are open for discussion to the panel and our speakers.
Okay, so I have some comments on that.
Yep.
So one of the things that I found has been really helpful is at least just educating my, so as an engineer, I have found it really helpful to, just in a class that I teach on devices for cardiac surgery, to make sure that there is an integration of a lot of discussion of awareness of outcomes and how they are measured, a lot of discussions on ethical issues as well, just to make sure that when students, more basic science and engineer trainees are learning about the devices and how they work, also just a connection with information about the patient. And I really like the information about the patient-centered outcomes as well. I think that Also, as you mentioned, incorporating more people on the boat of the politician and the patient. I think the politician is a good side of this, and just awareness of policy strategies and internships in the United States, the FDA. I think that inviting more of the policymakers to our group will be good in the future.
Sure, yeah. Peter,
yeah.
you want to comment?
Sorry. I think before focusing on standards, we need to define standards for whom. And so far, all our first world societies have talked about the few, the minority of patients in this world, because this is where the markets were. And this is a very crucial moment now, because this discussion can really perhaps lead to something which changes things, that we really talk about the same things, looking at things the same way. But we need to decide, are we just continuing to remain in the ghetto of the first world, or are we finally opening up and forget about the fact that right now the poor are not a great market, but it may well happen that they will have some lateral solution which gives them access sooner than anyone believes. And then we have a big dilemma, because we talk about totally different diseases, totally different cultural expectations, totally different socioeconomic circumstances for follow-up. So we can fine-tune now what patients feel, have they got pain after 3 or 5 days after a TAVI, but I believe we would miss out on a great opportunity to first define for whom are we going to standardize it.
But then maybe that might come to the question of what are the global standards that we could use. I mean, Elizabeth talked about ISHM, but Michael, maybe you can elaborate a little bit on that. I mean, you were talking about the PROMs. Not all of us are familiar with all that, and maybe in short explanation and what are the current available other global standards that are also up in the air right now? What are the different solutions that we can face? What do we have to choose?
Yes, thank you very much. I think that made a lot of sense that's just been said. I can, I want to say a few things. First of all, one thing that I have personally always liked about the ITUM approach is that it's so pragmatic, that it's just starting somewhere and bringing experts together and decide to create a set together. Because the thing is, you cannot change the whole world at once. You just have to start somewhere. Sure. And actually, there are a lot of instruments out there, and there is also competition between these instruments, but there are not so many international standards. So what we are, I think that's probably what we share with ITUM OECD. We are also very pragmatic. We are mainly interested in, having a system which we can communicate, that we can compare internationally, because currently it's a bit of a situation of many flowers blooming. So, but that does not necessarily mean that we should all move to one standard, because that would be probably difficult. But it could also be possible that we will work with crosswalks across these instruments. I don't want to make it too technical here, but there are several instruments that can be used. But in general, I think I know that there are many healthcare providers and hospitals that start initiatives and measuring outcomes, if you're doing that, just don't try to reinvent the wheel. Just first start with looking outside what's already out there, because there are so many things that can be useful and could be adopted.
Thank you. Yeah, you want
a few comments? Yeah. So I just agree with what Peter said, that for whom and those standards for, and also how would you enforce it? I know for the industry you have ISO standard, International Standard Organization, that is 5840 for the hub device that basically FDA, all these regular agencies, they follow those standards. They ask company to really finish all those testings and evaluate the device before they get approval. So the new standards coming from, I heard today, the question is that how would you enforce it? How would you get the clinicians and industry to really follow those standards and fill all these forms? I guess I bring more questions than.
Yeah, no, but I mean, you bring I think the right question I mean, if we say for whom those standards, I think the answer is for the patients, so that will have standards that are not focused on the device, but are focused on the patient's outcome, which was currently missing. But then comes the questions of who will pay, because there is a lot of cost. I mean, getting outcomes of patients medically or after treatment, to have these outcomes, it's a difficult task. It's a very difficult one. If we want to be exhaustive, if we want to have every patient that are enter into a healthcare system to get outcomes, I don't know if the Ministry of Health have been also that level of consciousness, or are they planning to finance that and to find a way? Because if the community is asking the medical community to provide evaluations of patients' outcome to evaluate the quality of care, how the community finance also that evaluation? Because that's a real question.
Can I respond to that?
Yes, please.
I just want to give one example, because I am originally from the Netherlands, which is a relatively small country, who recently decided to invest 70 million over a period of 5 years in a national strategy for outcome measurement. Why are they doing that? Because it will improve the quality of healthcare, but it's in the longer term, there's a lot of money is wasted on ineffective healthcare. So if you are better be able to measure these outcomes, it will also pay off in the longer term. And just asking the question who should pay for it is very interesting, because we don't ask that question very often about all these other data that is being collected all the time in healthcare. We are recording everything, more or less, and we all find that normal, except the outcomes of healthcare. So it's just a very logical next step, which will be helpful in avoiding a lot of waste in the longer term, I think.
Yeah. Yes, Peter.
Same topic, even on the payment side, pay for whom, and in that regards, again, we need to bring guidelines in. So we have guidelines which are based on the first world. We know that we have too little data to support totally different guidelines for the many. And now we have a dilemma that we are paying for the wrong things, because we are implanting mechanical valves into young people in developing countries, because the only guidelines available are those from the American College of Cardiology. And they have no idea that the majority of patients is dealing with a totally unsuitable recommendation. So before asking who is paying, we need to ask ourselves for what. And for the question of the for what would require that we address guidelines for the many. So it's again the same question. Are we still continuing to focus on the few and continue with the guidelines and then ask what are we paying for along these guidelines? Or are we opening up to the many and not paying for the wrong things?
But don't you think if we are able, as a multi-society, involving all the different people, scientific societies if we are able to set up those global standard sets, evaluating really the patient's outcome and being specific on the therapeutic, because I think this is one of the problems that I personally have with ISHOM. I think one of the, I noted that, and I had this discussion, I think, with Neil Bacon, who is the CEO of ISHOM, is that there is something that is strange into the ISHOM standards, is that they're evaluating the medical condition, but not the specialty procedure. And maybe you'll be able to comment on that, Elizabeth. But that comes to that it needs to be. I think if we're able together to have a multi-endorsement global standards, this will not be only for the 1% rich. It will be also for all the others where there is a need to evaluate. But it needs to be also centered on the therapeutic, because how can we evaluate properly the patient's outcome without being specific on the procedure? And for example, the ISHOM standard for coronary disease is not specific enough. For example, you're evaluating percutaneous or surgery without any more detail. And how can you evaluate patient's outcome if you're not precise on what CABG have been performed or what dilatation percutaneous treatment has been performed? So that's where I think we have a scientific responsibility to globally set up global standards, if I may say, as a multi-society effort. And the Heart Valve Society, by its translational position, surgical cardiology scientist, has the legitimacy to raise that task force to evaluate. I mean, to set up the evaluation tool that is needed, because indeed the guidelines they don't match. They don't match with the majority of the people on that planet, and even the Asian population who is rich. Regarding the size of aortic aneurysm, for example, is just completely nonsense to apply the ones that are used from North American people.
So, can I make
Anneke, yes, yeah. Please.
This is working? Yeah, great. Can I make a comment? Because what Peter is saying is very important, I think. When I look at opportunities in the Western world, what we see these days, we spend lots of money on healthcare. And of course, in my country, like yours, Michael, the Netherlands, we then invest in trying to contain costs and make the system move forward in a more efficient way while making sure we get the best treatment. So we have the money to do that, but there's a completely different situation in the rest of the world. And the question is, I think I know the answer, one model does not fit all. And that's only taking into account the differences in the national expenditure on healthcare, but in the rest of the world, access to healthcare, as you have and Liesel have shown so very clearly, is another major problem, of course. And the question is, would that work? Because as a heart valve society, we can only move forward, I think, if we take along everybody. But is that feasible with an ICHOM system? Or does that serve the whole world? I don't think one size fits all. So I find that very difficult. And another remark I want to make is that in the Western world, we already see a lot of standardization at a more general level. So there's a lot of societies, there's a lot of politics and health insurance companies involved. And so you also see a lot of politics going on. And so in that respect, we've noticed it's difficult to commit other societies because there's already a process in place. On the other hand, so that there's a challenge. The other challenge is in the rest of the world, the other 7 billion people on this globe, where healthcare systems are starting to develop in our field and do provide, I think, a great opportunity to start early in seeing how we can as efficiently as possible reach as many as we can. So I'm not really sure if one size fits all, but maybe one of you wants to comment on that.
So I would actually like to comment on that a little bit. I think when ICHOM began, there was very much a focus on the Western world, and I think that's one of the challenges that we have seen with our standard sets, that there is challenges in implementing these in low and middle income contexts. One project that I'm working on at the moment is with a group called Farm Access, where we're trying to use our pregnancy and childbirth standard set in Nairobi. And not only just that, but working with women in informal settlements, so slum areas, and using mobile questionnaires for them to answer these patient-reported outcomes. So in that project, we have used a subset of the standard set, because there were some, especially clinical aspects that we couldn't measure in those contexts, and I would say that from what we've found, that it has been successful to some extent, but that there are still challenges. But I think that we do need to have somewhere just to start, and even if you're not measuring the full set, just implementing what you can is a good start, and I think that's where we need to move towards to, and not penalising people for not using the full amount, but recognising the achievements that have been made.
Yeah, can I also respond to that?
Yeah, sure, please.
Okay, yeah, I totally agree with that. I mean, I cannot speak for ICHOM, but for OECD, we definitely not claiming that we are saving all healthcare problems in the world with the Paris program. You know, there are a lot of problems in countries outside the OECD with, you know, health coverage, having healthcare in the first place. So we're very well aware of that. And what we're aiming here is looking at people who receive healthcare. What are the outcomes of this care? So it's definitely not a panacea for all problems. But I agree with what Elizabeth just said. You know, it's already a challenge to develop something that works for 10 or 20 countries. Even within a country, these days there's often a lot of variation in the use of tools and instruments. So if we should start somewhere. You know, if you want to change the whole world at once, you'll never get this first step. And OECD I must admit, is an organization of relatively rich countries. It's the more developed world. That's true. So we'll start there, and maybe down the line we will expand to other parts of the world. But we just have to start somewhere.
Yes, Peter.
Sorry, I do disagree, because saying let's do what can be done now, let's start somewhere, will always keep up the wall between two systems which are wrongly perceived as having totally different interests, totally different abilities. If we stop appealing to the good side of people, but rather make it clear that there is a confluence point which people just don't see yet, which can even bring in profit ideas. So companies wouldn't come close to that boundary between the haves and the have-nots because they don't see profits. But I can just give you one example with Partner 3 now. Everyone can see where we are going with transcatheter valves in the rich countries towards younger patients. And you need 15 years or 20 in Europe or America to get an answer if a valve is a little bit better. If you provide valves to the young patients in the developing countries or in middle-income countries, you get the answer after 3 years. So to push across that boundary, instead of appealing on the good side and philanthropy side, onto the business side will help us to tear down boundaries which at the moment confine what is doable still to the area within the boundary.
Yeah, it might be good to conclude on that because we had a wonderful session. I think they're, rather than opposing those two apertures, I think they can be also this middle way that as you said, I mean, getting all the actors involved and will benefit to cross those limits. But I think as well, having global standards to evaluate heart valve disease and put the patients in the middle of the problem, in the middle of the boat, will be, I think, key to do not miss the point. Because right now, in this rich area of the world and OECD countries, we are focused on a market of billions of dollars, and sometimes, somehow, the main person, which is the patients, disappeared. And we're not focused on that, and the recent scandal of the implant files remind us how important it is to set up the evaluation tool. So I agree with Michael. I think at some points we have, I mean, they can be different battles at the same time, and definitely the one of evaluation with those standards that are coming, centered on the patients. I think if we're following that path, there is little risk that we get lost, because this is for the interest of the patients and actually for the interest of everyone that we can I mean, focus our efforts. So thank you very much for all of you, and thank you very much, Elizabeth and Michael, for being with us on this time, and all the speakers. And it was very interesting. Thank you. Thank you.